So I will speak about the role of TKI as a primary treatment option for patients who are not eligible for immunotherapy. First of all, there are two polling questions, so please answer rapidly to these questions. So the first one is, which patient group is eligible for IO first line? Okay, so we will speak a little bit about that, and I will show you that the groups of patients that are really ineligible for IO, this is something that we have to keep in our mind. This is a second polling question. How would you treat a post-liver transplant patient with advanced recurrent HCC in first line? So this patient has been treated by liver transplantation. He has now recurrence of the disease. And we have to treat him with a systemic treatment. So what will you choose? Okay, so a majority of you are choosing TKIs, and some are choosing immunotherapy, and we will see that probably it is not the best. So what is interesting for people that are a little bit, I would say, old in this field of GI oncology is that during a long period of time, we have absolutely nothing to treat the patients. And a little bit more than 15 years ago now, a drug was approved, and this drug is sorafenib, that remained an active drug in the treatment of hepatocellular carcinoma. And after that, there were a lot of approval with different types of drug. Majority of this drug were TKI, and the era of immunotherapy and combination of immunotherapy and anti-angiogenic agents or double immunotherapy, as it has been presented by Timon, occurred since a little bit more than 2 years now. So we are in really a new era with a lot of drugs for the treatment of this patient. If we look on the recently actualized HCC guidelines of ESMO, you can see that in the BCLCC patients, so it means extended disease, there are two main options. The standard of care is atezo-bev, and it will be atezo-bev and durvalumab, but there remains as an option sorafenib and lenvatinib. Why? Because we know, as I already said, that sorafenib is an active drug. It has been proven by the SHARP trial, but also by the ASIA trial, showing that when you are giving to patients with extensive hepatocellular carcinoma, the results in terms of overall survival is better with sorafenib than with placebo. And after that, there is another trial evaluating the role of lenvatinib. It was a trial of equivalence showing that lenvatinib gave the REFLECT trial results in terms of overall survival that were quite similar, I would say even better than sorafenib, but this is an equivalence trial, and there was no statistically significant difference between the two drugs. So there are two options in the first line. There were two options of the treatment of first line advanced hepatocellular carcinoma. As I told you, there remains this option in the ESMO guidelines. So who are these patients? Do they exist? That is the question I would like to try to answer and to discuss with you now. First of all, clearly, patients with liver transplantation, we know that this is probably the best treatment for hepatocellular carcinoma. And when patients are well chosen, the recurrence rate is quite low. And we have very, very good survival in these patients. But unfortunately, some patients, I would say 10 to 15 patients, will recur after liver transplantation. And what we know about these patients is it seems that when we see them with a recurrence, the median time to recurrence is 14 months in this series. Some of these patients had the recurrence that were available for a treatment with curative intent, hope of cure. But we see that 40%, at least 40% of these patients will need a palliative treatment due to an extended recurrence. And this is presented there for some patients. You can see that only a few patients have a liver-only recurrence, a lot of patients have a liver and extrahepatic recurrence, and the majority extrahepatic only recurrence with metastasis either in the bone or the lung or lymph node or even peritoneal carcinomatosis. So it means that they are very good candidates for a systemic treatment. A point that I would like to discuss too is the role of immunosuppression in the incidence of recurrence, because we know that we are giving, it's obviously needed to give to these patients immunosuppression after liver transplantation. What has been demonstrated is that there is no clear influence by the use of corticosteroids and antimetabolites. There is no difference between the use of cyclosporine and tacrolimus, but it seems that higher exposure to calcineurin inhibitors, so cyclosporine and tacrolimus, within the first months after liver transplantation is associated with a higher risk of recurrence. And for that reason, specialists in liver transplantation try to decrease as soon as possible the doses of cyclosporine and tacrolimus that are given after liver transplantation. But the series are very scarce. Could we use in these patients immunotherapy? The fact is that at this moment, the data that we have are very interesting, but show a high level of allograft rejection. So it means that it remains very dangerous to give to these patients with a recurrence after liver transplantation, either ipilimumab, nivo, pembro, or any combination. So I would say that after liver transplantation, there is no possibility to give IO to these patients. So if we do not give to these patients IO, it means that we have to use the other types of treatment, and especially TKI, sorafenib, and lenvatinib. Do we have data concerning this use? Yes, we have. We have data concerning the use of sorafenib in these patients. With it, and it seems even that sorafenib is working better in patients after liver transplantation than in patients with I would have said before liver transplantation, or in patients with their primary tumor in place or with a recurrence like that, probably because the problem of the cirrhotic liver has been treated by the liver transplantation, and thus there is no problems, no consequence of liver failures that are related to the liver disease and not to the hepatocellular carcinoma. We have data, so sorafenib is a clear option, and we have even data on the sequence with sorafenib followed by regorafenib that shown again very interesting data with a disease control rate that is not so bad, a median overall survival that was 14 months in this series. And if you look on the median overall survival from the start of sorafenib, it was even 32.6 months. So it means results that are quite interesting, even if we don't cure the patients. And if we look now, this was a series, international series. If we look now on the meta-analysis, you can see that the level of 1 year survival rates in this publication was not too bad, around a little bit more than 60% of the patients were alive at 1 year. So it means that, again, this is not too bad for these patients. With lenvatinib, we have less data because the drug is a little bit more recent. But again, we have very similar data showing quite good median overall survival, 14.5%. So it means that this is another option for these patients. Before liver transplantation, is it possible to use IO in these patients? We have no answer to this question. That is a very important question because there is a remaining effect of the administration of immunotherapy that could be a little bit dangerous. Probably we know that this combination of IO plus atezobev or durvalumab in terms of response rate is the higher ever seen. But the fact is that the risk of donor graft rejection after liver transplantation is so high that at this moment it's impossible to recommend this use. We have only a few patients that have been treated with 2 patients among 10 who died from rejection. That is something that is absolutely not acceptable. Another topic and another category of patients that cannot receive or maybe receive sometimes immunotherapy is patients with autoimmune disease. What type of autoimmune disease. Obviously, in these patients with HCC, we can see hepatobiliary autoimmune diseases that are responsible of cirrhosis, such as primary biliary cholangitis or primary sclerosing cholangitis or severe autoimmune hepatitis with a cirrhosis. But there are also other autoimmune diseases, such as rheumatoid arthritis, type 1 diabetes, hypothyroidism, psoriasis. So what we know is the fact that probably the level of risk when you are giving immune therapy to these patients is clearly not the same. If it is only a problem of thyroid, as we said, for toxicity of these drugs, when we are treated them, we just have to replace the lack of thyroid hormone, and it is easy to do. For other diseases, it could be very dangerous for the patient, and we had only a few data on that. This multi-center retrospective cohort study is probably the best one, with a little bit more than 100 patients. And what has been observed is that more than 70% of the patients will have either a flare of the pre-existing autoimmune disease when they receive immunotherapy or other immune-related adverse effects, probably because they are very sensitive in terms of immunity to any kind of stimulation. So at the end, the recommendation at this moment, and it has been published recently in the Gut journal, is immunotherapy should be avoided when reactivation of autoimmune disease may be life-threatening in those with neurological, especially in this kind of diseases, neurological or neuromuscular diseases, or in those on high doses of immunosuppression. And at the end, something that we have to keep in mind is the fact that when we are looking on real data, and this has been very recently published in the European Journal of Cancer, even if this is large series real data, nothing comparative, not a randomized trial. But if we look on a large population of patients that have been treated either with lenvatinib, TKI, or with atezolizumab, bevacizumab, the results in terms of time to progression and overall survival of lenvatinib are not so bad when they are compared to atezolizumab, bevacizumab. So please do not consider that in all the situations, lenvatinib or sorafenib is something like a low-cost treatment for these patients. This is a treatment that can really be active, and we have to know that. A specific few slides now to coming at the end of this presentation. Patient with a significant bleeding history. It has been presented by Timon. Really, there could be a risk. So first, it started with these pool questions. A majority of you prefer for this patient durvalumab. That is absolutely understandable. Atezobev is really not a good option for these patients. TKI, lenvatinib, and sorafenib increase a little bit the risk also of bleeding. So it has to be discussed case by case, I would say. If you want to give a standard of care for this treatment, and if the risk of atezobev of bleeding following the use of atezobev, really the best treatment at this moment is durvalumab, tremelimumab. And I will finish on that. The etiology of the liver disease, there is some concern. We don't know exactly if this treatment, immunotherapy, combination treatment that have been recently approved are working with the same level of activity in different etiology of cirrhosis. And for instance, with atezo and bev, it seems that the treatment is working better in patients with hepatitis C or all the hepatitis causes of chronic disease than with patients with non-viral liver disease, such as in France with a lot of alcoholic cirrhosis. So this is something everybody is working on that, because in the durvalumab trials, the results were a little bit different. So we are coming now to the discussion. So I would be happy. I wasn't able during my talk to have a look on the chat. I apologize for that, but I have only 2 eyes. So I have to look on that. And maybe Timon or Shangu, do you have a question for me about my presentation?
Yeah, I thank you, Michel, I think, for this very interesting presentation. I had a question. You showed data that liver transplantation after IO can be dangerous. Do you think that there is never an option to do a liver transplant, or how long should we wait before doing a liver transplant?
Yes, that is the most important question. What we may imagine in this setting is to know a little bit more, but we will need really a lot of data, and especially from immunologists about that, because we don't know yet for how long period of time it could be dangerous to perform a transplantation. There are already some data concerning kidney transplantation, showing that it could be done not too long after the use of IO. So I think this is a completely moving field, and we have more and more data in the near future about that. Thank you for the question. It's a very good question.